And good morning, good afternoon, good evening, wherever you are in the world. Welcome to this week's IMCO Maternity Natural Health webinar, hosted here by the International Integrated Maternity Healthcare Organisation. And I am very pleased today to bring along Shelley Harris-Stoddart, who is a fellow Kiwi midwife. So say hello, Shelley, and introduce your daughter.
Hello, hi, good morning, Kathy. Yes, this is my lovely daughter, Storm, who's watching the webinar as well. So shall I get started, Kathy?
Well, what I'm going to do is just do a little bit of introduction. So the topic, of course, here today is about sexual and reproductive healthcare services in the humanitarian context. Is normal physiological birth critical or even possible? So Shelley, just a little bit of background on her. Trained as a midwife in the UK and has spent the majority of her 20-year career working in Northland in New Zealand, which is also where I happen to live. And she's what we call a case loading or self-employed 24/7 on-call independent midwife, and seeing the benefits of continuity of care, when you're looking after a woman through the antenatal, at the birth and postnatal, and the benefits of autonomous midwives and communities who maintain that strong normal birth culture, which with all the regions of New Zealand, we'd have to say probably Northland happens to be the strongest of the regions for normal birth culture. And although it is pretty strong in New Zealand anyway. In 2018, Shelley began working as a midwife activity manager with Medecins Sans Frontières, the Doctors Without Borders, which is a worldwide humanitarian organisation, and she has worked with the MSF teams in Yemen, Afghanistan, Bangladesh and Uganda, providing maternity and sexual reproductive health services to the local and refugee populations. And I have to tell you that Shelley is naturally kind of shy, and so I twisted her arm to be speaking to you guys today because I know she is this amazing wealth of knowledge. And for those of you who are not familiar with the system here, we'd love to see you put your information up in chat, which is down at the bottom of your screen. So that would be wonderful if you let us know where you are in the world and your role as a health professional. And then, of course, if you've got any questions for Shelley, you can just put that into the Q&A down the bottom, and we will make sure that we go through those questions. So I'm going to hand over to Shelley now, and she has a PowerPoint of slides that she's going to go through with you. And yes, so welcome along everybody, and hand over to you, Shelley.
Thanks so much for that introduction, Kathy. Morena, welcome. Thanks for listening in. As Kathy says, I am Shelley Harris-Stoddart, a midwife, and I'm speaking to you from a very wet, damp Whangarei location this morning. I'm a strong advocate of normal physiological birth and have been involved in midwifery for almost 20 years. My own journey through pregnancy and birth was a life-changing experience and motivated a powerful advocacy in me for women, for gaining consent and optimizing women's ability to fulfill their innate potential for childbirth, unhindered by the medicalization of birth. In a world of rising intervention rates, such as induction of labour and caesarean sections, my research and practice supporting normal birth began. I've been fortunate to work in midwifery across the globe and witness some of the challenges faced universally and some of the challenges faced in wealth-poor, war-ridden countries and displaced communities, whilst I work with MSF, Medecins Sans Frontières. I'd like to present this morning a glimpse into those worlds, the tragedies and the everyday miracles. We will look at the state of the world's maternal mortality rates and in relation where MSF has projects serving populations in need. For an idea of how humanitarian sexual and reproductive health and maternity health is delivered, I'll show you examples from the projects I've worked in Uganda, Bangladesh, Afghanistan and Yemen. We'll see some of the structures care is given from and some of the teams who provide that care. Then we'll talk about some of the lessons I've learned from my personal experiences in the field. To begin, let's have a look at a worldview of maternity outcomes through a simple lens, the maternal mortality ratio. Every day, approximately 810 women die from pregnancy-related preventable causes, 94% of which occur in low to middle income countries. These numbers have been reducing over the past 25 years after a worldwide focus through the Millennial Development Goals on reaching maternal and infant mortality, on reducing these ratios. In some countries, the rates have dropped by as much as 60%. The map on your screen shows the maternal mortality rates, which is the number of maternal deaths per 100,000 live births worldwide. In stark ratio to New Zealand, Australia, and the EU average of 6 to 9 deaths per 100,000 live births. Sub-Saharan Africa, Asia, and the Middle East experience the highest rates. For example, in South Sudan and Chad, over 1,140 women per 100,000 live births lose their life. In Afghanistan, it's 638 per 100,000, and Uganda, 375. There's a massive variation across the globe. Across these countries with the highest rate of maternal mortality, we also see the highest rate of infant mortality, the highest fertility rates, which are the numbers of babies born to one woman in her reproductive health life. We also see in the same areas the least number of skilled birth attendants. One of the leading ways to reduce maternal mortality rates and ratios is when birth is attended by skilled midwives. If we consider the leading causes of maternal mortality, which are blood loss, hemorrhage, antepartum and postpartum, infections, unsafe abortions, eclampsia and hypertensive disorders, obstructed labours and prolonged labours, we can see that these conditions are treatable, thereby preventable when recognised. Attendance by skilled midwives who can recognise and respond to deviation from normal make life-saving differences. Many of the countries where the highest mortality and morbidity rates occur are also where conflict, political instability, poverty, food crisis, and displaced populations inhabit. The second map on the slide is taken from the 2020 MSF Annual Activity Impact Report, and it shows the 88 countries where MSF is delivering humanitarian care. They have a very large presence in Sub-Saharan Africa, the Middle East, and Asia. MSF is predominantly a medical service based on foundation principles of neutrality and impartiality. This means that people are treated irrespective of religion, race, their beliefs, or political affiliations. They are also an independent organisation receiving funding from 7 million individual donors and private institutions. This allows MSF to respond independently, to engage rapidly and with flexibility to meet urgent needs. Here are some examples of the MSF facilities where sexual and reproductive health care and maternity care are delivered. The first picture shows Bolamoni Health Centre in the Yumbe district, northeast Uganda. Locals and refugees from South Sudan present here for care. It is built of wooden frames with a canvas cover. It houses an outpatient department, inpatient department, pharmacy, and the crucial blood bank. Here in the maternity department, there was an average of 120 births per month, and antenatal care, postnatal care, family planning, and safe abortion care services were delivered. If a caesarean section was needed, the woman was referred to Arawa, which was a 2-hour bumpy ambulance ride away. The second picture is of Pahara Udi Hospital on the hill in the Cox's Bazar mega camp in Bangladesh. This service serves the Rohingya refugee population from Myanmar. It houses a 24/7 obstetric and emergency department, a 7 days a week sexual health and services, so antenatal, postnatal care, family planning, and safe abortion care again. The third picture shows Khost, Afghanistan. This is one of MSF's biggest maternity projects, and it's housed in an ex-military hospital which was converted. Here in this facility, which is in the foreground of the picture, almost 2,000 births occur every month. It's a simple single-story building with a delivery unit holding 9 delivery beds, a postnatal ward of 32 beds with an average stay for women of 6 hours. There is an operating theatre for caesarean sections and a neonatal unit. The last picture is the reinforced tent that houses the Emergency Surgical and Maternity Centre in Mocha, Yemen. Inside the tent is the emergency room, maternity triage, an operating theatre, and an intensive care unit. This tent has a specially designed layer over its top to prevent it being pierced by any stray bullets. The centre was located quite close to the active line of battle. However, that line moves, and so now it's in a safe area. The service initially treated war wounded and trauma cases, but because of the operating theatre, acute critical maternity cases presented, and so the maternity project began. An average of 80 births per month happen here. As you can see, these facilities are somewhat different to the facilities we as midwives practice in New Zealand and Australia. The teams who operate the services are comprised of predominantly national staff recruited in country. They are the heart of MSF and hold the local cultural knowledge and skills accumulated over years with MSF. A small team of international field workers, often around 8 to 14 in number, join the project and the national teams for around 6 to 9 months per assignment. There's always a diverse mix of people. It's a really international organisation. Most projects also provide links to community through outreach services and health promotion services. Again, these are staffed by nationals, often with an international manager. Although MSF's ultimate aim is to empower national staff to operate and maintain the service long after MSF withdraws. An example of a team well adapted to the needs of its service users is the team in Khost, Afghanistan. This is purely the maternity project, which delivers the 2,000 babies per month. It's also known as the baby factory. The labour and birth suite and the postnatal ward are staffed by only women. In this deeply conservative Islamic community where segregation of male and female is critical, lest shame be brought upon the woman and her family, the midwives, doctors, obstetricians, cleaners, and translators are all women. The labouring women can behave freely, move freely, dress freely, and feel safe to do what they need to do to birth their babies. This is a really successful project. So how best to serve, engage, and support normal birth? What I've found in my experience is that engaging with the communities served and their own maternity care providers lays a foundation for sharing knowledge, understanding existing practices, and finding ways forward to treat women and babies when complications arise. An example of this is in Cox's Bazar mega camp, where the Rohingya refugees who fled persecution in Myanmar are now living. A challenge in this project was the late presentation of pathological conditions like severe preeclampsia or hemorrhage after postpartum. When care was sought, the woman or her baby were already in critical condition. We worked alongside the traditional birth attendants who were themselves refugees, but who continued to deliver home-based care in the camp. The TBAs knew nothing of trimesters, but discussion showed that they also divided pregnancy into 3 stages. The first chapter, which included loss of menses, feeling unwell, and altered sensations in the body, for example, breast tenderness. Then came the energized chapter of growth and activity. Lastly, the weighty, heavy chapter before birth. Having found common ground, like these 3 chapters of pregnancy, we could frame meaningful discussions on how to identify abnormalities and hasten their referrals from the community to hospital when complications arose. Holding workshops for both national staff and for community-based rural midwives created a forum to update and refresh knowledge in the community. In this setting, we could discuss scenarios encountered, and midwives shared with each other how they resolved these problems. An example being in Yemen, when the community-based midwives referred their complicated clients into the MSF facility. We could give feedback at the workshops about outcomes for their clients. We talked a lot about how to preserve normal birth, because this was something that clearly needed to happen because of the high number of obstructed labours and prolonged labours we received. Hydration, basic hydration in labour, basic bladder care, eating in labour, monitoring progress, and upright forward-leaning positions were discussed. To preserve normality, we would receive women whose labours were obstructed purely because the bladder was so full the babies couldn't pass by. We found that being supported by family was already an important feature of facilitating normal birth in these communities. Fluency in supporting the normal birth, alongside recognising abnormalities like delay, malposition, bleeding, abnormal headaches, vision and swelling and pain, and when to act upon them, made up a big part of these workshops. Of course, there were still many challenges to face. One challenge faced in many maternity projects is the liberal, uncontrolled ill use of oxytocin and misoprostol. These medications begin contractions, and so they are easily purchased in these communities through pharmacies. They're misused by people giving health advice in the community. When labours didn't start as expected, or where a latent phase was long or progress slow, these drugs were given freely in the community to women. The misuse gave rise to obstructed labours, hypoxic neonates, and sometimes even uterine rupture. They just didn't understand how the drug should be used to good effect. It's a serious and ongoing problem that engagement with the community and education really will make a difference to remedy. Further, how to best serve and support women. In 1985, the World Health Organization stated that a caesarean rate of 10 to 15% was a realistic reflection of the need for caesarean to prevent increased maternal and neonatal mortality rates. This tells us that a normal birth rate of 85% is also realistic. When women need help, they really do need recourse to caesarean section. But the greatest majority of women would be able to give birth naturally. The caesarean section rate in Khost, Afghanistan, the baby factory, holds at around a very low 4 to 5%. Caesarean section is used if an absolute indication exists. For example, placenta previa, malpresentation, shoulder, brow, chin posterior face presentation, or absolute fetopelvic disproportion, obstructed labours, uterine rupture. And they would also perform a caesarean section if a woman had had 3 previous caesareans or a classical incision. Anything less than 3 previous caesareans, the woman had a trial of labour and often achieved vaginal birth after caesarean. Should pathology arise in labour, the decision for caesarean was balanced with the risks of a scar on the uterus of a woman who may go forward and have many subsequent pregnancies. The risks to the mother with a caesarean scar on her uterus are high in these contexts. Rurality, lack of services, risk of infection, high fertility rates, and risk of uterine rupture in subsequent pregnancies mean a caesarean is done only a life-saving procedure. This is also very dependent on the consent of the woman, and more so her husband or the father of or her father. It's very clear, however, that caesarean sections should be performed based on individual circumstances and need, rather than based upon achieving a specified rate. Unusual normal births happen frequently in MSF settings. For example, breech births and multiples. In Horst, so many multiples were born. Remembering also that women present in strong established labour to these facilities, they have unmedicated labours, i.e. they don't have any pain relief, no epidurals, no opioid medications. And they also don't receive continuous fetal monitoring. Vaginal births of multiples, twins, triplets and quads was very common in Afghanistan. Midwives had become very skilled in delivering multiples. It's normal for them. During the 6 months I was there, 95% of all multiples were born vaginally, even the 3 sets of quads in a 10-day period that presented. These vaginal birth skills have been honed by experienced MSF obstetricians sharing their skills with the supervisors of midwives who then supported the midwives, working alongside each other in supportive, empowering ways so the skills of the one specialist remain with the national staff in the project. I saw watchful, engaged midwives supporting these births, with an obstetrician standing by and recourse to caesarean if needed. They worked together respectfully, but not fearful of the birth. There's no doubt also that the women in Khost province, Afghanistan, are very strong, stoic women in labour. And now to breech birth, and an example from Mocha, Yemen. The midwives in Mocha, Yemen were very experienced, mindful and prepared, hands-off breech births. They were experienced with these births and practiced them frequently. Breech presentations occurred there at a rate of 4 to 7% monthly. The midwives always observing for progress, confirming full dilatation, and having recourse to caesarean section should pathology arrive. Breech vaginal births were considered normal here. Women, again unmedicated, were active, seldom on their backs and more often kneeling. Techniques such as watching for the chest cleft and the umbilical cord through the chest cleft as the body descends, and the shoulder press, where to assist the birth of the aftercoming head, worked really effectively if some hands-on support was needed. These techniques I learned about in the Breech Without Borders trainings. Now, these trainings are available to anyone worldwide, and I'd highly recommend them if you're a practitioner that wants to increase your confidence in working with vaginal breech births. Breech was also not an indication for caesarean section in Khost, Afghanistan, although the births were more often than not facilitated with hands-on manoeuvres there. I saw there a manoeuvre I hadn't seen before, although it's well documented in the MSF Essential Obstetric and Neonatal Guidelines and represented in many of the diagrams, one of which is shown here on the slide. It involves the use of suprapubic pressure in conjunction with a modified Morisot maneuver applied to the aftercoming head should it become entrapped. I've seen this work very effectively in urgent circumstances. For every breech birth, resuscitation equipment is prepared in all settings. The need for resuscitation is initially higher for breech presenting birth than cephalic. Another unusual presentation often experienced in MSF settings is the face presentation, and these babies are generally born vaginally. As mentioned above, however, a face presentation with the chin posterior cannot be born vaginally, but chin anterior can be, because there is space for the head to flex and sweep over the curve of Caris to achieve flexion and be born. If a chin posterior baby can't be rotated, then a caesarean section is crucial. These skills to identify pathology and to facilitate normal birth in these unusual presentations has been really, really useful, coming back to my home and working with women when these positions and presentations occur unexpectedly. There's certainly incredible knowledge and skills to be learnt in these MSF settings. As we draw to a close of the presentation, there is no doubt that there are ongoing challenges in these contexts. There are complex factors involved in care provision. People experience food shortages, low income, and therefore poor nutrition. Many women are anemic when they present to our services. The very status of women places them in vulnerable positions. And when women are displaced in refugee camps, when they are head of family because their husband is lost in war, they are vulnerable, very vulnerable to sexual abuse and violence. In many places as well, there is a lack of maternity services, a lack of antenatal care services, a lack of reliable antenatal care. So complications and congenital abnormalities are missed until they are critical enough to motivate the women to seek urgent care. They will often have to leave their homes and their existing children because there just isn't the support in these communities. It's very, very challenging life. Accessing the care, accessing reliable maternity care is also very challenging, where roads are poor, where the security on the roads and the safety is low and women are vulnerable, or there is conflict, active conflict occurring. Cultural practices can place women at increased risk in pregnancy also. Factors like early marriage and child brides, female genital mutilation. These things cause great pregnancy and birth complications, as does the practice of unsafe abortion. And as we've discussed, the easy access to synthetic oxytocin and misoprostol, causing intense hyperstimulating contractions. These are ongoing challenges to maternity care provision in humanitarian contexts. The world needs midwives. Skilled midwives make a difference at home and worldwide. Supporting normal birth under these circumstances is challenging, but women are equipped. Their innate potential to give birth is strong, and 85% of women will give birth without complications. requiring interventions like cesarean sections. Recognizing the 10 to 15% of pregnancies where pathology is occurring is critical so that they can reach life-saving treatments needed. In summary, we've talked about the numerous complex challenges when providing sexual and reproductive and maternity services in under-resourced, war-ravaged, unstable environments or to displaced populations. Early identification of pathology in pregnancy, intrapartum, and postnatal can provide greater opportunity to treat. To see deviation from normal and act upon it is really important, and that care is provided by skilled midwives. The support and preservation of normal and unusual physiological births strengthens the woman's ability to birth physiologically. Emergency responses, skilled midwives, and service availability saves lives. That brings me to the end of my presentation. Thank you so much for your time and attention. I hope that it's been helpful for you.
Oh, Shelley, it's just been absolutely
if you'd like to
fascinating.
review.
Yeah.
Thank you. Hi, Kathy. Thank you so much. If anybody would like to follow up any of the documents that I've talked about, or to find out more about working with MSF, or if anybody is tempted to join MSF and offer their skills to help this really important work, there are some links here at the end of the presentation that they can follow through.
Absolutely. And in 24 hours or so from now, everybody registered to attend this webinar will get an automated message from Zoom where we're going to be including these links as well. Or if you can always come through to me or us through here at IMCO, and we'll have a record of those links. You must find it such a dichotomy to be working in a Western country and then where you've got easy access to medicine and often you might be sort of feeling like it's that cascade of intervention that's intervening where it really doesn't need to be too early, and then you're in this environment. I mean, it must be just so crazy going from such extremes of care. How do you sort of process that, I guess, particularly when you come back into a westernized environment of birthing? Do you feel like you want to sort of hold your hand up to the obstetricians perhaps sometimes and go, stop, it's too early, we can still keep this normal? How do you work that out?
It is really challenging, and it is like night and day. I think that both settings have their challenges, and we face massive challenges here in New Zealand and in developed countries where caesarean section rates are skyrocketing. I think in Northland, where there is this strong birth culture, that the obstetricians here and the core midwives, the midwives who work in the hospital, are committed to facilitating normal birth. But there are things which complicate physiological birth that are very much part of maternity services in developed countries. Things like epidural, pain relief, choice. These things create completely polar opposite challenges.
Yeah,
and
exactly, because that intervening of the particularly epidurals, because they just affect every part of that labor.
Yes.
And it takes a woman from being low risk to high risk, which is why continuous monitoring is required of the fetal heart rate, because now she's in a high risk situation. And so it's so interesting, you find that when that's not available at all, and that stoicness of the woman comes because there's no option. This is it. You do your labor. the 4 to 5% C-section rate in Afghanistan is pretty mind-blowing. That's amazing. And of course, the comment, I found it so interesting, your comment that it's always major abdominal surgery, and it should never be looked at in anything less than that, even though it's done so often around the Western world. But the point that woman is going to be left with a scar on her womb, that when she still has years of reproductive life ahead of her. So I don't think that's something that is really much thought about in the Western world, thinking, oh, this woman may have another 10 pregnancies, or,
Exactly.
right? It's
exactly.
Yeah, it's not really a consequence, it's really part of it.
Especially, that's right, Kathy, and especially because services are so easy to access here.
Yeah.
So that if there are any problems, then they can reach the care they need. And a big difference between the two settings is actually the antenatal care, that antenatal period where things are discovered and acted upon early. This is something that would make a huge difference in those contexts. That care just isn't available, and so women go through their pregnancies, and they just don't pay attention to the warning signs until it becomes critical, and they have to seek urgent care, which is often too late for the baby and sometimes for themselves, and they sustain things like fistula, obstetric fistula, and this is another big problem in the communities. Yeah. So there are a lot of challenges for sure, and I think that that in Western countries, that just the gratitude for the services available. I don't think people really imagine how difficult it can be without those services. Yeah.
Yeah, you're absolutely right. And I think that it's funny because I myself was interviewed a little while ago for a podcast, and one of the things that came up in discussion was the quickness that we see today, women willing to complain pretty strongly about service they've received. And we know that, of course, everybody's trying to give their best service, and it doesn't always happen, and things can always be improved and whatnot. But there is a sort of whereas if we go back to, say, in the 50s and 60s when my mother gave birth, you didn't question anything that charge midwife would say or do, yes. And now things get questioned, and women have got access to Google, and so it's a different kind. It's like there is that little bit of entitlement that comes in, and you must find that pretty challenging in a way that you sort of think, goodness, you've got access to some of the best care in the world, and I see women who don't have access to that. Just be grateful and stay kind. I think some of our viewers could find it quite interesting to hear a little bit of the process of you going from being in a position of thinking, oh, I think I might like to work for Doctors Across Borders, and actually, being on site doing that. What was that whole process from you? How does the interview go? What sort of time does it take? How does that all work?
Hi, that's a good question, Kathy. Thanks. So Medecins Sans Frontières has massive resources and information available online. They will put out messages to people interested, people who contact MSF, about the information nights. They hold information nights. They used to do that in person, but now everything is online, so it's easy to access. They have webinars about the services they provide, about the different people they're looking for, doctors, obstetricians, midwives, anaesthetists, that kind of thing, nurses. And so there's a lot of information available in those webinars. Also, so that you get the initial information, then apply to MSF. If you're you're interviewed. If you're accepted for an interview, you go through an interview process. And then when you receive the go-ahead that you've been recruited, there's a 3-day training that is delivered to field workers before they go. And this talks about what to expect, how to take care of yourself in the field, how MSF takes care of you. MSF really looks out for their field workers. There are projects that are very high security contexts like Yemen and Afghanistan, and there are more stable settings like Uganda and Bangladesh. And so first time missioners, they will be sent to a more stable, complex setting normally. So that process from gathering the information to actually being in the field can take as short as 2 to 3 months, or
Wow.
it can take 12 months, depending on the service that you know, your profession and what they need at the time. And I know that MSF is now, MSF Australia is actively recruiting midwives. So if there are any midwives out there that want more information, jump online. And I can't recommend highly enough this
Wow.
experience and what you'll gain from it.
Minimum commitment that you're giving to them is about what, 6 to 8 months, or what's the minimum and the maximum? How does that work?
Yeah, so initially the first mission would be 6 months, and MSF have specific missions for first timers, and once you make that commitment, you know, that can be the beginning of a long career with MSF. Yeah, so it's 6 months commitment initially.
And I guess everybody's going to wonder that question: how do things work financially?
Hi, that's another good question. So as an MSF field worker, we do receive a basic salary, monthly salary, and insurance and travel is all paid for by MSF. There's also a daily per diem payment that's made to help pay for your food in the field. So actually it doesn't cost MSF field workers anything to go and volunteer. Probably they would earn a lot more in their profession at home. This is not something that we do for the money, but you can maintain cover your expenses at home from what's paid. Yeah.
Right. Okay. So depending on what your rent or mortgage or things are
Yes.
at home, that's probably going to be coverable, and they're looking after you in the field for your food and whatnot. So you're not going to be saving any money on this, not at all. And I don't think anybody would think you would, but it's financially viable that you can do it, and without digging too deep into your own pockets.
Exactly.
Okay.
Yeah.
And
yeah,
who?
exactly, Kathy.
Yeah. Okay. That's just fascinating. And is there a level of experience that they look for with their midwives and their doctors, their obstetricians? Are they saying, look, if you've only been out as a student, you know, if you've only just completed your, you know, you need to have years of experience? What are they after with that?
Yes, that's right. That's true. No, inexperienced people, it's not what they're looking for. They are looking for experienced practitioners. If I remember rightly, it's at least 2 years experience before you can apply to be a field worker with MSF. Yeah.
Right.
Yeah.
And
It's not the place to be. You need a strong foundation in your practice, really.
good.
You're going to be placed in situations that you've never seen before, and that requires a lot of previous experience, I would say. Your work is supported with the Medecins Sans Frontières guidelines, practice guidelines, and these are available online. You can get hold of them and read them anytime. But the way that care is delivered is based on these guidelines, and they're well researched, they're up to date, they're based on current best evidence. So that's really, really a key factor in being a midwifery activity manager, so that consistency of practice takes place over all of the projects. Another thing is that every project has its own birth culture. And so the projects are functioning projects when you arrive as a first missioner. And so really these projects are where you learn how to be a manager. Often we as midwives, clinical midwives, will join MSF and have no management experience of managing a unit. And this is something we learn on the way, and it's something that those teams teach us. So it's really important to go in and observe, just to watch what's going on in the project and not make any changes, really, at least because the project is functioning and functioning well. You can identify where you might like to make some changes and explore those and go slowly and gently. And the most important thing is to involve the teams on the ground, not to go in and make sweeping changes, because that's the way it's done in your experience at home. Yeah, these contexts are very specific and very unique to where they are. The populations are unique, and so you can learn so much just by watching and observing before making any changes.
And your clinical skill sets of feeling not fearful with unusual vaginal births, that must be just mind-blowing, really. Particularly all the multiples in Afghanistan, how fascinating is that? That's quite it's that's amazing. That is such a strong part of women's bodies over there, that they are producing all these multiples. That is so common. How amazing is that? And having breech birth regarded as a normal variant of vaginal birth, with the face presentations, it certainly makes a few of us go, wow. Yeah, so amazing. And that's actually how I got to know Shelley, was because we were both attending an emergency obstetric care workshop, and the knowledge that was coming out of her, the oozing out of her to do with unusual vaginal births, was just fascinating. And gosh, it was almost like we wish we could pick up every Western midwife and obstetrician and just drop them into Yemen for 2 weeks or something, and just say, right, now get confident and come back. And because they are certainly, particularly breech birth, is something that is a skill set that is really just disappearing. You can have obstetricians who may get to the end of their entire career practically these days and have never done a vaginal breech birth, and midwives too. So we're losing our ability because they are seen so little. It's just fascinating. What would be the I'd have to ask the question, what have been the things that surprised you the most, that you just you were shocked at what went on, or how things were done so well in comparison to what we do in Western birthing suites?
I think really we've talked about those really significant things, the approach of the culture around how births of multiples, how breech births, how they're approached in those settings, simply because they just don't have the recourse to cesarean section, perhaps initially, and also because the referral to other hospitals is often arduous, and there just aren't the services. So I think that some of this knowledge and skills have come about because of very poor outcomes, and the need to improve and learn how to deal with those births in a safe way. Yeah, I think also some of the surprising things were how quickly the medicalisation of birth can be spread amongst cultures who you would expect to have been strong physiological birthers. I know that a lot of refugee populations are used to upright standing labours and squatting and birthing their babies. And in some communities, I find that the medicalisation of birth, where a lot of women were asked to lie on their backs and birth with their feet, with their legs up. So there are challenges that we face going into different contexts. The culture of birth is so different in every place, and midwives are very proud of their practice. So some of the things that we talk about a lot is upright active birth and getting women off their backs. What's surprising is how well vaginal breech birth goes when women are on their backs, but also, of course, when women are active and off their backs, vaginal breech births often birth themselves. But I would never be blasé about the risks involved with birth, and it always requires that attention. I think the midwives of Host were astounding with their skills, with so many births happening, 2,000 a month, and only nine birthing beds.
Oh my gosh.
Yeah. That really is astounding. So there could be 60 births in a night shift. And so this team
on 9 beds.
Yeah.
Wow.
And so, you know, it has to be a really slick operation, and the skills that the midwives have are just astounding too. So the women will come to the delivery unit fully dilated from the labouring room and have their babies, and then go to the postnatal ward where everybody catches their breath a little bit, but 6 hours later they're home again. So those midwives, we worked on skills, communication skills, gaining consent, eye-to-eye contact with the women, just to try and really keep that human component of birth in such a busy unit. But those midwives, very, very skilled at reducing the risks of postpartum hemorrhage, of helping babies to be born. Yeah, quite astounding.
Wow, that's phenomenal. The numbers, that must be one of the busiest birthing suites on the planet.
I think so. And there are another couple like that within the MSF in different countries, but yes, it's got to be. Incredible stories. We could just, I could listen to you for, I could listen to you for hours, Shelley. I just hear it, because you must have such a library of amazing individual stories, and that you've, amazing. So look, we are running out of time now, but thank you to all of you who and I have to say, just really scary to know that there's easy access to oxytocin and misoprostol, like just in the community. And we, as midwives, we know these are serious drugs that have serious hyperstimulation potential, and that's pretty scary, isn't it? Oh, look, we've had some lovely comments coming through here. So lovely comments of thanks to you, and amazing. So thank you so much, because I did twist Shelley's arm a little bit to come and talk to you all, because I know that she's just an amazing midwife with an amazing lot of skills and a beautiful person, and thank you for what you're doing, and for letting us have a little bit of insight into what you've been doing over these past recent years.
So thank you very much. And thank you to those who are here live. I just wish, anything in closing that you would like to add, Shelley?
I would really recommend, if you're tempted to, or are thinking about working in a humanitarian context, I would really encourage it. It's the experiences are profound. You learn so much that enhances your practice back at home, and you really make a difference in those communities. Yeah, skilled midwives save lives. Yeah, thank you so much for listening. Thank you, Kathy,
thank you
for your
so
engaging
much,
conversation. Really enjoyed it. Thank you.
Okay, and bye everybody. You have a lovely rest of your week, and we look forward to hopefully seeing you next week.
Thank you.
Bye everybody. Thank you, Shelley.
Thank you. Bye.